Be an advocate for the patient and their family. Second is do not focus on yourself. Focus on the situation. The third one is get the patient's perspective and get the patient to agree with you because they would be the most powerful one. Hello, welcome and kumusta. Thank you for joining me. This is How and your occupational therapist. Welcome to OT Conversations. And in this episode, I was just thinking about some of the usual practice and the usual encounter that we have as occupational therapists. Well, very seldom me anyway, because over the years I've learned to manage this. But I have been observing a lot of therapists whom the family do not seem to get along with all the time. And I'm just trying to figure out a way on or give you any tips on how you can make it so that the family is really working with you and you don't get aggrieved by family. The first frame of mind really when I encounter difficult families is that I see them and I make sure I let them know that I am on their side. Okay. So how do I do this? I'd say, yes, I'm an occupational therapist first and foremost. You are my boss. That's what I say jokingly and with a smile. I am your advocate and I will speak on your behalf. That's what I do. So that's the first thing that I would say to the family, that they are the boss, I am their advocate. And then I would say, equally, what I will do is I will let you know what NHS or what the position or what the trust's position is regarding your care. And if there is a need for me to go and clarify things with the doctors, I will do that for you. Okay, so that's another thing. That's another technique. So letting them know that you are there for them and do that with a smile. Okay. And you are in the team patient. That's what I would say. Because if you're not in the team patient, patients would see you as in the team institution. That meant you're the one that is causing the problem. And it will be a problem even more if you insist on doing that and you want to stick in that position, that you are in a position of authority. That'd be a problem. Be an advocate for the patient. The second one would be minimize or try to break away from the word I. Because when you say the word I all the time on the patient, they will target the situation over to you as a clinician and perhaps even as a person. So you want to target the word I, minimize the word I, okay? And that means where do you want to focus now? You want to focus now on the situation, okay? Focus on the event and the situation. An example would be, hello, my name is How. I am your occupational therapist and I am your advocate. And let me give you some feedback about where we are. This is the situation. With regard to your mother, in this case, the patient is somebody else's mother. The situation is that the doctors, from a medical perspective, it's not even quoting the doctors, from the medical perspective, they're happy, meaning that the reason why your mom was here medically has been addressed. It's been controlled, so that's one. From the perspective of your mom's physical abilities. So this is now you talking and giving feedback about the physiotherapy performance. Okay. From the physical perspective, your mother is doing quite well in terms of the walking. In fact, she managed to walk the length of the ward with a physiotherapist without an adaptive aid. Or you can say, in fact, she was able to walk in the length of the ward safely with the use of an adaptive aid. And she's been given a frame and it makes it safer. Yeah, that's the second one. And then in terms of their function, in here at nighttime, she was standing, she was walking, she was getting out of bed, she was walking to the toilet, manages to look after herself. Okay, that's that. And you're not really talking about you, but you're talking about the situation and the feedback. Because all of these situations is something that the family will hopefully translate into what the demands are at home. So the other thing that you need to do is you can get the consent and the agreement of the patient with you. So how do you do that? So you find out the tasks at home. What are the things that you need to do at home? What are the things that you need to do at home, for example? And say you need to get out of bed, which you're doing here, and walking to the toilet, things like that. You're wiping your bottom. You're doing well. And when you do that, you can ask the patient themselves, how are you feeling? Do you feel well in yourself? Yeah. And when you say that, make it so that you are like giving little suggestions by nodding. Yes, you feel well in yourself. I think you're doing well, don't you? And then they would say, oh, yes, I feel well. Because being part of, say, being in the hospital means that there are some anxiety and you can't take that anxiety away, especially if the person's gone through a lot of things like heart operation, lung operation, they've been in critical care, and people will be anxious. But then everything else is stable. And when it is, then it is up to you and it's up to us to help, to recommend, to make that recommendation on how the person will improve and how the person will acknowledge that they are doing well. And that get the consent and the agreement of the patient. That's the third one. So the first one was, what was it again? Be an advocate for the patient and their family. Second is do not focus on yourself. Focus on the situation. The third one is get the patient's perspective and get the patient to agree with you, because they would be the most powerful one. So between the patient, if the patient and yourself are speaking on the same theme, if the problem is their family, they can't do much about it. Okay. The other technique that you can use is make decisions with family and take them through the process. So what's the situation and how do I want to do that? For example, a patient is, say, in the hospital under your care and family is anxious, for example, and they wanted carers for their mom and they're afraid of leaving them alone. Okay, so this is the scenario. But the patient is independent and they wanted carers, right? And this is very usual where parent or family would want carers for their next of kin who's in the hospital. And then you can go and ask them, okay, first is acknowledge their worries. I really acknowledge how daunting this might be, how worried you might be. Okay, so that's one, you've acknowledged that. And then the next thing would be, in fact, this is very common that that everybody in a similar situation as yours are share the same problem and concern. So you're not alone in this. So let them know that what they're going through is not unique to them, and it is something that is very common. And then the next thing would be, let's take them through the process. So how are you going to take them through the process? Say you want carers, okay? So this is me hypothetical speaking to the family. Okay, so I acknowledge that you have concerns, and mind you, there's a lot of people in a similar situation like yours. So just to reassure you that this situation you're in is quite ordinary and quite common for a lot of people. So you're not alone here. Okay. But I understand that you wanted carers for your mom. Say we get carers for your mom. Let me take you through the process. Okay. We'll make a functional status report based on what she can do. Okay. Based on what she can do here in the hospital. So they'll be asking, can your mom get out of bed? Yes, she can. And then you get the confirmation. If the mom is there, you can get out of bed. Can she walk safely? Yes, she can. Can she go to the toilet? Yes, she can. Can she wipe her bottom? Yes, she can. And if it's things like that, and they'll be asking us, what would the carers be for? So if you say it in that respect, you pass that on to the family, and they say, so what would the carers be there for? And then the family will be thinking, really, that's true. There's nothing else. Okay. And if you can't think of anything else, it's even more difficult for other services to justify what can be done. Hey, so that's the other thing. So you've taken them through the process. You got them to make that decision for you and along with you and on behalf of every other things, letting them see things through. And then the next thing is a reassurance as well. And you need to equip the family and the patient of the things that they need to do when you have discharged them. Okay, so what do I mean by this? It meant that, like, when she goes home, we're expecting that your mom will be fine, will be independent as she is here. So your mom is independent here. So she's actually doing quite well. But should there be a problem medically, yeah, and for example, she gets chest pain or she gets these, all of a sudden she just has difficulty doing things because she feels unwell, things like that. You can say, we are not anticipating her to be unwell, but every now and again, things like that happen. And if that's the scenario, I need you to ask advice from your GP. That's the first point of call. But if it is something of more concerning to you, then go and ask for a like emergency services like 999. And there we go. So you have equipped them now with the things that they needed to do. Okay. So what about, so that's one technique as well. Get them through the process with you. The other technique is do not be quick to offer anything yet. Let the offer be the last minute. Okay. If you are faced in a scenario where it's a medical case, a quick respiratory case, cardiac case, surgical case, normally, once you have sorted out the impairment, the physical impairment, you've had the operation, there shouldn't be any functional impairment apart from low endurance. That's all there is. Okay. And you shouldn't be quick to offer adaptive aids, or you shouldn't be quick to offer carers. So how does this work? say in the acute nature of the condition, say post operation, if you ask a person on 2 days about whether they feel carers, yes or no, on the second day of admission, and they're not feeling very well, they are likely to say, yes, they will need carers and they cannot manage. That is because their point of reference is then and there. Their reference is how they feel at the time. As an occupational therapist, you need to know the prognosis, the functional prognosis of these conditions. And what does these conditions entail? Like, for example, if you have a chest infection, yes, you'll have difficulty walking because not because of the legs, but because of the breathlessness. And it's going to be a struggle. Okay. And if you're going to do the things that you normally do, doing the gardening, you can't do that. Or getting into a bath, that may be difficult. Or preparing a cup of tea or cooking, that may be difficult. Or shopping for yourself, that may be difficult. Okay. So if you ask somebody with a respiratory problem at that early age, they would say, yes, I need help and I need carers. Okay. What one way around this is on the initial phase, the functional prognosis, once they get well, then they will improve. What you can do is you can acknowledge that state. What you can do, one of the techniques would be, okay, I acknowledge that you feel this way. Okay. But you're still having your treatment. And I understand and I respect that this is how you feel. This is probably what you think you need right now. But what we're going to do is I'm going to keep an eye on you. We are going to work together. I will regularly visit you. So there is that point where you reassure the patient. And we are going to review your abilities because I am certain, again, this comes with experience. I'm certain that after when you feel better, your position and your perspective could change. Yeah. Okay. So there you go. So that's the technique. That's one of the technique. Do not promise straight away. Do not ask straight away whether they feel they need it. And if you do, and you know that they're going to improve at some point, you need to give them a reassurance that this is not a situation where you're going to be in forevermore. Amen. This is a situation where it is part of the condition and the situation where the person is in or where they are in. Okay. So that's that. Quite a few techniques. And then the other thing is do away or avoid with the negative thoughts and negative talks, in the sense where, oh, it's not my problem anymore. I cannot help you. It's beyond me. Okay. So yes, you're saying those things and they're factual, but there is an emotive, negative tone on how you said it. Okay. So like, for example, yes, I've done all that I can. Okay. So it's like, I've done all that I can. Geez, if I'm hearing that, you know, then if I was listening to somebody saying somebody saying to me that they've done all that I can, then for me, I would just go, get off my face and find me somebody who can do more than what you can. Because it just gives an impression that you are limited on what you can do and you've done all that you can. Okay. So what's a better way of saying that? So rather than I have done all that I can, okay, so we have reached the limits of our expectation. So we've managed to achieve the things that we needed to achieve and the things that we needed to work on, all the concerns we have addressed. And there are no other problems that we can identify at the moment. And so far, all is good because all the problems that we've identified in the first place were all addressed and were all sorted out. So you see how that was phrased? So rather than I've done all that I can, wrong, you can use that in a very supportive manner. And there is that reassurance from the patient, reassurance from you that they have reached that level that they needed to achieve, which would be enough and would be safe enough for the person to go home. Okay. Or I have no clue. Oh my God. When you go, not my patient, not my worry, not my problem. There you go. Those are some of the things that I frequently hear. We have to be in a position to help. Okay. So that's what we need to do. Okay. So do away with that. I have done all that I can. No matter how nicely you say it, no matter how nicely you speak of that. Okay. Also, the other technique is when you're speaking to the family, your position has an influence, and your position in terms of physical location when you're talking to them has an influence on how they are with you, and it has an influence on your interaction with your patients and their next of kin. Your posture has an influence on that. There are lots of therapists out of fear, understandably, would speak to family with their hands on their waist. And that's annoying. That's intimidating. It's like you're asserting yourself. People are asserting themselves in their position. And if you come across with family who is by nature has a quite an authoritative figure, then they will counter argue with you all the time, and they will not be working with you. Instead, they will mirror that activity. So be in the position to help. At the end of the day, we're all there to help. And if you apply all of these things, I hope that you will be able to make your days easy and fun and exciting, because it's not you against the patients, it's you with the patients, and you will have less of the problem that is provided and given by the family. Okay, there you go, guys. I hope you enjoyed this talk. Just remember, anything you do matters and has an outcome. Until next time, bye.
If you enjoyed this podcast, talk to your friends and colleagues about it. Like it, subscribe, share, and do what you can to appease whatever algorithm that is at play. Just remember, guys, anything you do matters and has an outcome. Until next time, bye.